Welcome, friends, to this special episode of NTB Dialogues ahead of the Union World Conference on Lung Health. A week ago, the Lancet published findings of a very important randomized controlled trial in Tanzania and Mozambique, which compared the difference it makes if we deploy the molecular test Truenat at primary care level versus transporting sputum sample to a remote lab with a molecular test GeneXpert, which is, say, 10-16 kilometers away, and getting the report back. The difference was found to be astounding indeed. The study shows that 1.5 times more people could begin their treatment within 7 days when tested with Truenat at primary care level versus those who got tested in a remote lab with GeneXpert. And not just 1.5 times more people could begin treatment within 7 days, but 4 out of every 5, that is over 82%, could do so on the same day when tested with Truenat at primary care level. Only 3% people could begin treatment on the same day if they were tested in a remote lab with GeneXpert. So the science is very clear on taking the point of care molecular test to point of need. What a big difference it could make if we take services closer to the communities and people. If we are to end TB, we have to find TB early and accurately and begin right treatment as soon as we can without any delay to help people heal faster as well as stop the spread of infection. Ending delays between diagnosis and treatment initiation is so critical to save lives. With these words, let me invite our keynote speakers today. Both are among the researchers of this important randomized control study and are among the authors of the Lancet article. I invite Dr. Celso Khosa, Director of Polana Caniço Health Research and Training Center, Instituto Nacional de Saúde, Mozambique, and Dr. Adam Penn Nicholson, Deputy Director, TB Program 5. Welcome, Celso and Adam. Can you please tell us more about the study and its importance for the global TB response, especially in high TB burden settings? Over to you.
Hi, everyone. Thank you for the invitation. I hope you can hear me.
Yes,
properly.
Very clearly. Yes.
Yeah, Adam, if you allow me, maybe I can start.
Please.
So in high burden settings like Mozambique and Tanzania, most of the TB patients will have access to care and for diagnostics and treatment through primary health centers. It means that people in remote areas, people with less conditions, will only reach care in primary health centers. So if the capability for diagnosis is not available where people have access, basically what you have is a delay because people need to look for diagnostic and for care farther from their homes, but also it also takes time to get results back. So this, I think the main message from this study or the importance is that we can make diagnostic, quality diagnostic, quick diagnostic closer to the users, closer to the patients, closer to the people that need to be screened or to get a TB diagnosis. Adam, to you.
Thanks, Dr. Celso, and thanks everybody for inviting us today to talk about this, I think, a very important topic. And I think what Dr. Celso said is exactly that. I mean, the placement of the instrument changes the speed in which diagnosis is made and treatment is initiated, and that then cuts down on transmission. And where our objectives are to allow better access to treatment, better diagnosis so that nobody falls through the gaps in diagnosis. One way to do that is to expand testing. But I think really what this study shows is that even without more tests being done, it's the placement of that instrumentation in that test that allows the treatment to be made faster and lives to be saved. So while we want to also expand testing, right, to encompass more people, or people who are not only driven to primary health care by symptoms and targeting and allowing people who are asymptomatic to also be screened in more rural and remote settings. I think what this very much shows is the effectiveness of initiating treatment faster and how it can be cost effective as well, where there's a paired paper that will come that shows that we can do a lot more with the tools that we have if we just put them at the right place and have the health systems to support them. Thank you.
Can we have some results of the study from you? What the most astonishing results, of course, but it would be nice to get it from your mouths itself.
Oh, all right.
Adam.
Yeah, we can talk about it. I think there's a lot of results that come out of it, but this was first and foremost, I think, just to acknowledge the many people who were involved in making the study a success. Of course, the participants and their families who have been the bravest of the lot, right? This is the dedication and commitment that people provide. There are many consortium partners as well, beyond just Celso and I representing. And of course, the funders from EDCTP and the European Union who allowed this to be possible, and Molbio for their donation of the instrumentation and the tests and their commitment to advancing testing and making it accessible for all. But generally, this was a study conducted in 2 different countries and in two institutes per country, so 4 institutes, Tanzania and in Mozambique, where Dr. Celso is based in Maputo in Mozambique. And within it, there were 29 primary healthcare facilities that were identified and randomized. So it was a cluster randomized study where I think we split, was it 14 into an intervention arm and 15 into the standard of care. 15 into intervention, 14 into the standard of care. The intervention being the placement of the Truenat instrument and MTB plus test and the rifampicin resistance MTB RIF-DX test at the sites of the clinic. And then the standard of care was off-site gene expert testing. And so what this means normally is that a patient arrives at the clinic with symptoms. They would produce a sputum sample if able to, and this is a limitation, but we can talk about that in the context of today. And then in the standard of care, that sample is normally transported a day or 2 or 3 later to a centralized facility, maybe 10 or 15 or 20 kilometers away, on a tuk-tuk or a motorbike or such, where testing is then done remotely, and we then now need to get the results back to the participant, who by then has long since gone home, and we hope will be contactable at another stage. And so I think that's the basis of the design of the study. By putting the tests at the clinic, we really hoped primarily to see if we could reduce the time to treatment initiation on a 7-day window, right? That was our primary objective. We also looked at this over a 60-day window. That was a secondary objective. But what we landed up showing, and maybe Dr. Celso, if you're willing to talk a bit about the results then, is how we actually saw so much more treatment provided on the same day of testing, which is a remarkable outcome. And maybe Celso, I can hand to you, but happy to step in as.
So thank you. So looking at our primary outcome, we could see that looking at the 7 days window, 97% of participants on the Truenat arm versus 62% would start treatment within that window. So basically, we could see that almost all the participants would start treatment on the people with TB, with confirmed TB within the 7 days. This was not a primary objective of the study or one of the objectives, but we could even see that the majority of these people will start TB treatment on the same day where they are tested. So this changed a little bit how we do or how we perform TB treatment, because it shows that it's possible to test and start treatment at the same day if you have the tools in place to do that. So that's a very important message. And I think this, I always say that the TB community is always a little bit behind the HIV community in terms of innovations. And here we bring the concept of testing and treat on the same day to TB with this study. Additionally, when we look at the complete, the whole population of the study, we can see that we have 73% on the Truenat arm versus 4.8% initiating treatment within 7 days. So I think the results are clear that when we place instruments at the facilities, clinicians and health professionals are able to provide care much faster than when they have to send samples and wait for results. And even we lose less patients because patients don't need to come next day or 2 days after to get their results, but they can get results on the same day. So basically, I would say that in summary, our study shows strongly that testing and treating on the same day is possible when you have an instrument that people can use and the instrument is available at the facility where people get tested and they can get care there.
I think maybe to also just help frame the scope of this, because we didn't mention that this was over 4,000 individuals enrolled across these two countries, which is a large sample size, and I think so important to recognize because that gives us the study the power and the strength to make the outcomes interpretable. And it's not the first study that's done this. Another one had been done in Uganda under the EXPEL trial. There they framed it slightly different and it was more historically based on outcomes. The randomization wasn't the same, and it was done with expert instrumentation, which were placed in clinics, but we know not to be as robust as the Molbio instrument that has a wider functionality at a range of different environmental temperatures and is not as sensitive to the dust concerns that are seen elsewhere. Also, I think that study, and it's an important outcome for our study as well, is that the primary objectives were focused on initially proportion of individuals who initiate treatment by day 14. And then the objectives were changed at one point to be the absolute number of participants who received treatment by day 14. What we did is we made it slightly more compact. We took it down to 7 days as our primary objective. And that allowed perhaps a faster turnaround is what we expected. But it's also important to say that in this setting, in this study, patients did land up accessing treatments within, I think the median time to treatment in the control arm was 5 days later. So there was a gap, but there wasn't a different number of people or proportionality overall by day 60 who initiated treatment. But I think what's really key here is the timeliness on accessing that treatment.
Yes.
Maybe, Adam, one other important thing is also that when we look at the empirical diagnosis, in the clinics where we had the intervention, we also had fewer clinical diagnoses, but also, this gives more security to the clinicians to when they can look for differential diagnosis when they have the tools in place. So I think that's also another important takeaway from this study.
Yes.
Adam, you were talking about problems in getting the sputum. Can you say something more on that?
Yeah, I think there's systematic reviews that show that almost 50% of people with microbiologically confirmed TB in a sputum sample are asymptomatic. Okay, so firstly, what that means is people are not showing up at the clinic if they're not feeling sick. So that is a limitation in access, on recognition. Yet those walking well are very likely transmitting the bug, right? The other problem is that people who do show up at the clinic may not be sputum productive, and so there is a whole host of new tests that are going to WHO GDG review in a couple of weeks, where it's a tongue swab based test, and we're very excited to see this advancing. In fact, Molbio have a mechanism, a platform in which this is being tested, and there's other partners who are doing similarly. But I think that availability of sputum in its own right is a limitation on how accessible the test becomes. And certainly then the health-seeking behavior based on symptoms is a limitation too. So the more we can get these tests decentralized, not only to the primary health centers, but also out and into the field, into the communities, dare I say, even into households, we'll find more people with TB. One of the challenges there is trying to convince people who don't feel sick that they need to now initiate treatment. And so that is a lot of work we need to do in working with the community for sure. Yeah.
Right. In fact, there have been many studies and many surveys in different countries which show that 50% were asymptomatic patients.
Yes. In fact, I saw a paper just today, I can drop it in the chat, saying household contacts in adults in South Africa, almost 80% are asymptomatic of the TB cases. And I'll see if I can find that paper and drop it into the chat.
There is a question for you, Celso and Adam, that how many samples can be processed at one run and how many samples processed per day using only one device?
Adam, I think, yeah, go ahead. Yeah.
Yes. So for the Truenat instrument, there are different flavors. There's the Uno, which has a single chamber for testing. There's the Duo, and there's a Quattro, so 1, 2, or 4. So depending on what instruments you have, the test overall to get a result can take 60 minutes. There's some processing, so let's say 60 to 90 minutes. So you can run 2 tests in an hour back to back. I think it's quite feasible to do, if you have a duo, to do 10, 12, depending on the staffing and the timing and when the specimens come in during the day, even up to 20. What I think you don't want to do, and what we want to avoid here, is having a limitation on the instrumentation. So all the participants or patients would come in at the morning, and then there would be a backlog of specimens to test throughout the day, maybe resulting in some of those patients only getting a result at the end of the day. I think that decreases the value likely to the patient, because we want to know if somebody comes in, they're happy to sit, and we can get a result out in an hour and a half. Mm-hmm. But I actually am not the person to answer that question. I would dare say Mr. Sriram from Molbio is probably better placed to answer the speed and throughput of that.
We'll come to him, and we are also waiting for the swab test to come soon out in the field, because that will be a big game changer, I think. Yes. So we are looking towards that. So thanks to both of you, Celso and Adam, and we'll be coming back with questions as they appear in the chat box. And our next speaker is Dr. Samantha Tinsay, Municipal Health Officer, Bantayan, Cebu, Philippines. Dr. Samantha is one of those who have already walked the talk on the findings of this study. With help from Stop TB Partnership, she has deployed point-of-care, battery-operated, lab-independent, and decentralized WHO-recommended molecular test Truenat and AI-enabled ultra-portable X-rays of Fujifilm, and demonstrated solid impact on finding more TB and treating them successfully and saving lives in the islets of Bantayan. Welcome, Samantha. Over to you.
Hi, everyone. It's actually 9:30 in the evening here in the Philippines. So I'm here in Cebu, and I just wanted to talk about the impact of the Truenat in Bantayan. Previously, our patients would travel about 3, sometimes 7 hours to get to a facility to get tested. And if you're not familiar with Bantayan, it's actually located in the northernmost part of Cebu province, about 5 to 7 hours away from Cebu City. So you would have to drive 3 to 4 hours and then to reach the port. And then once you reach the port, you have to take a ferry for an hour to 2 hours. So just having the test available for the patients makes it so much easier for them, because instead of them traveling 3 to 7 hours, spending their entire paycheck to get to the city, now the test is available to them right where they are. And I really saw that impact when we started using the Truenat back in 2022. So we started with it in the USAID INTP project. And to this day, we're continuing it. Thank you for the donation of Molbio for letting us use the Truenat in the island. It's really, really helped my patients. And I'll just show some pictures because I know people are more visual learners. So let me just show a picture of what I'm talking about here, the island. Can you see my slides?
Yes.
Okay. Yeah, so this, I just wanted to show that the support that we received also from Molbio and Gets Healthcare, the subsidiary here in the Philippines. They actually came to the island and trained our staff. So this is one of the members from Gets Healthcare training our lab tech and our medical technologists on how to use the Truenat. And this is the Truenat in the field. That's actually our medtech / model, Jake over there. So you can see we can use it either with electricity or without electricity because it also comes with the battery packs. And what we've seen is that we can go into a community or a barangay and we can do the test there. So instead of the patient going back and forth to the clinic, to the city, what we do is a one-stop shop approach. So the patient comes in, they get their chest x-ray, we have the AI read it, and then at the same day, they also get their sputum tested using the Truenat. But we don't stop there. We also do a combination where we also test for HIV at the same time and give treatment for drug-susceptible TB at the same time as well. But sometimes our patient will get tested and they'll come out as drug resistant. So we also have the medications for that as well. But as you know, with drug resistant TB, we also have to do additional testing, such as checking their creatinine and things like that. So there's other process for that as well. So the Truenat is actually, so far we've tested many patients in the field. With the X-ray alone, we've tested over 15,000 patients in 3 years. But with the Truenat, we've tested a couple hundred because now we're bringing the test to the people. So this is one of our active case findings there in the island. As you can see here, I just wanted to show that we bundle the services. So when we go into a community, we're not just focusing on TB, we're also bundling it with immunization, with family planning, HIV testing, free medical consultations, and dental checkups, so that we're not wasting resources. So you can see how the impact of bringing point of care testing to the people. For me, it's really revolutionary because the approach is to make things more equitable for people, to have equitable healthcare. You have to bring these tests to the people. You don't have to wait for them to come to the clinic because sometimes people don't have the resources to do so. So now we have the technology, we have the tools to do it. Why not? Why not bring the tools to the people? So for me, these things are revolutionary, and I'm just so grateful to be invited here today. Thank you.
Thank you. Thank you, Samantha. Thank you very much. And just a moment. Yes. And now I invite my close friend and guide, Dr. Arlina Burhan, who is on the board of directors of International Union Against Tuberculosis and Lung Disease, or the union as it is called. And she's an iconic TB researcher and lung health expert at Indonesia's famous Persahabatan Hospital. Thanks, Erlina, for joining us today. Over to you.
Thank you, Soba. Hello, everyone. Good evening. I'm from Jakarta. It's 8:30 now in Jakarta, 8:30 p.m. So quite late, but I'm happy to join since Soba told me that this is a very important meeting. And also, I read the article from Lancet comparing this new PCR that near point of care or even point of care testing that I found from the research is very relevant to the situation in Indonesia. You know, my country is a archipelago country which consists of 17,000 islands. 17,000 islands with a variety of infrastructure regarding to the facility, etc. And in respect to TB testing, there are not so many laboratory that can do a PCR testing. And if we do so, it's only in the cities or in urban area. There are very limited facility for PCR testing, and from what I read in the Lancet that this new near POC testing that really significant yield, having a significant yield in not only finding the cases but also putting the people of TB into the enroll of the treatment. So this is really good because when we use this conventional diagnostic tool, such as in remote area, we have acid fast bacilli, but in some urban area, we do have expert. But again, experts, as you know, there are some requirements that need to be fulfilled, such as stable electricity and also very trained, not trained, but I mean the sophisticated facilities. So it is not suitable to the very remote area. And I think having a device that can be bring to the community and then get the result in 30 minutes or 1 hour, that's really something very relevant and significant. And I think by having this in the remote area, in the rural area, we can bring the service to the community and directly we can decide it, then we will put the individual into the treatment or not. So rather than sometime in my place, we have to wait until 1 week is the rapid, the very fast time, but usually even 2 weeks or even more before people after sending the specimen get the diagnosis and put under treatment. So this delay can lead to the massive transmission to others. So I think in the conditions such as in Indonesia, in my country, with a lot of island, remote area, and also a lot of facility that, in Indonesia, we have 10,000 primary health center. But not all of them having expert. For instance, even if they do have a lot of presumptive TB, they need to send the specimen to the let's say district or sub-district facility. That will take some time, and then to get the result also will take some days, and then decided to put the patient into treatment also need an effort because they need to wait for the patient to come and asking for the result, or even to trace them and bring them into the facility. So this is one of the condition that I think we need to try to implement this new innovation, to have a rapid test and with a less facility that being needed, and also with not so sophisticated effort. So if there is any PCR testing that consider as a point of care or near point of care, I think this is very suitable and I will endorse this kind of technology. Thank you so much, Soba.
Thank you very much, Erlina. And I hope now Indonesia will see more of these Truenat machines at the primary healthcare level centers. Thank you very much.
I do hope that too. Thank
Yes.
you so much, sir.
Imagine 25, 26 years back in the late 1990s, when there was no TrueNat or gene expert. We had biosafety level 3 laboratories with RT-PCR. Sriram Natarajan was one of those who dared to innovate to develop real point of care molecular tests that can be deployed at point of need level in resource limited settings. Welcome, Sriramji, Director and CEO of Molbio Diagnostics. Your game-changing innovations, be it the world's first point-of-care malaria test or the only WHO-recommended real point-of-care, battery-operated and lab-independent TrueNat, are making a huge difference in reaching the unreached. Thank you, Sriramji and Team Molbio. Over to you, sir.
Thank you, Shobhaji. Thank you for the good words. First, I must start by thanking FIND and the team at TB-CAPT for doing a wonderful study. We are extremely happy to see that what we were envisioning in Molbio to have our technology work at the community level and be able to turn around results to enable treatment on the same day is actually happening and has been shown and proven through a very well-constructed and well-designed study, which has been done on a large pool of samples. So very happy to see that they've been able to do this impact that is now clearly documented. As we know that TrueNat has been implemented in India in a pretty large way. So India today is testing about 10 million TB tests on TrueNat. And I think the Indian data shows that it's impacted quite significantly and leading to a lot more case detection happening, which were otherwise getting missed. And again, TrueNat is now already into the programs in Nigeria, in Peru, in Kenya, in Bangladesh, and many other countries. So clearly, we're happy to see the impact that TrueNat is creating. And as we go along, we hope that this technology will be deployed much more widely and enable more communities worldwide to enable not only for tuberculosis, but also for the multiple diseases that can be tested on this platform, so that communities are getting strengthened to do multi-disease testing right next to where the patient is, so that early detection can happen and early treatment can be initiated and people can be cured of diseases which are completely treatable, of which at the moment many of them are dying. So that's our vision. And as Adam pointed out, Molbio is also working on newer technologies. There's already one technology which is currently undergoing validations for WHO for testing tongue swabs. So this is coming from the fact that many people, especially people who are asymptomatic, do not produce sputum. And so how do you test for pulmonary TB in these patients? So sputum swab testing and tongue swab testings are being looked at as options. And we have a solution for that, which is currently undergoing studies. And hopefully they'll get endorsed at some point of time. So we'll be able to also meet these kind of requirements for testing for people who don't have ability to produce sputum. Additionally, I can say that there are at least 3 more new technologies for TB that's coming up in the next year, which will make TB testing even more complete solution. And all the gaps that exist today, we expect them to be completed and fulfilled, so that everybody will have an access to affordable TB diagnostic tests and also tests for multiple diseases at the point of care. So that's the vision for Molbio. And we will continue to strive to see that we're able to provide more and more solutions. So that's just a statement from Molbio. But happy to say that we are very encouraged with the study and it will only motivate us to do a lot more. Thank you very much.
Thank you, Sri Ramji. And we are really looking forward to many more of your innovative diagnostic technologies taking shape in your labs right now that will contribute towards a healthier world. We are waiting for that. Now let me invite my dear friend and inspiration, Lisbeth Arup, Head of Project Development, Humana People to People India. Her team has developed a person-centered model to reach the unreached and help support them to be agents of change in not only getting tested, but also finishing the treatment. Her team has worked with those who are hardest to reach, including the homeless people and migrants. Over to you, Lisbeth.
Thank you very much, and good evening to all from Delhi. Yes, first of all, thank you to Dr. Adam and to Dr. Celso for this interesting study. And I would share with you also some very good results we have had with during the last 6-8 months. See, we were disrupted with our work in the field among what we call the key vulnerable population that we defined as homeless people, migrant people, people living in the urban low-grade slums, not even the, you can say, the normal slums, but mainly the really low-grade slums. We have we were disrupted in our work in the beginning of Feb, but on the World TB Day on the 24th of March, we again started our work together with Medanta Hospital, who has equipped us, or we have been working together with them to get X-ray out in the field where people are. And since then, we have been able to screen 3,674 people. And this time we have had, we found 25.7% people presumptive cases, 947. And we got 95% tested. And what was very good this time, it was after the 100-day campaign was initiated by the Central TB Division. We were in that good situation that all, apart from 3 people, they were tested with NAT, because now all the chest clinics in Delhi that we have been working with, they have been equipped with Truenat machines and they are full up and running. So that resulted in that we, during this time, found 61 people with TB, and 59 of them, meaning 97%, they have started treatment. And we are very happy for that result because it is much better than just 1 year back, when we also had a big project in Delhi and other urban areas where we screened many more people and tested many more people also. But at that time, just 1.5 years back, we had only around 30% of all the presumptive cases, they were tested with NAT. The rest of them, they were tested with microscopy. And that led to, from the same group of people, that we had 1 per every 100 people tested that were with TB. But now we have seen that it is 1 per 60. And that is thanks to, I would say, Molbio, and of course also that we have found a good number of presumptive cases, but that we already had both with verbal screening and X-ray. So I would say that the combination of course, that now we have been able to find more presumptive people, but definitely that they have been tested with NAT instead of microscopy has given us, I would say, 40% more people with TB. And then because we have a very thorough follow-up and supporting people to initiate treatment and also to stay on treatment, that also in the end leads to that people complete the treatment and are cured. So that is what I would say. It is very, very good with the NAT. Definitely it saves a lot of lives, and it gives also courage to many more people to actually get tested, and because they can see that it's possible to get treatment. So that is what I would say. Thank you to Molbio and thank you to you for this good study. And then I have a question to you, Dr. Adams, because you mentioned that when we come up in this, you can say, high number of people tested, then it also becomes cost effective. So then I would, of course, like to ask you, how much is that in dollars when it's cost effective? Thank you.
And thank you, Dr. Lisbeth, for your commitment and the story that and the sharing of your data as well. And a very good question. I have put in the chat a published cost effectiveness paper that all can refer to, and there's also an extended cost effectiveness that has just been accepted, and hopefully in a couple of days, once we get through the publication release process, that will become more available and can be shared more broadly. But generally, I think what I can say is that it's country specific, right? So the cost of the test is the MTB and the RIF-DX chip, in my mind, is quite low and has been, I think, hats off to Molbio for bringing that cost down and sort of forcing other approved manufacturers to also similarly try and reduce the costing. So I think it's really allowed greater access. However, the cost of placing instruments at these PHCs is more than would otherwise be if they were just located in high throughput centralized testing facilities. So I think while it's very country specific, I think I've got some data written here. The cost per person tested in Mozambique was $51 for Truenat versus $39 in the centralized testing. And in Tanzania, it was $40 versus $22. So it's about a health systems process as well and transportation. What was seen is that the cost to initiating treatment within the 7 days and the time frame for that initiation, it comes down dramatically as soon as you start to scale testing up, right? So if you're doing 3 or more tests per day, it becomes cost equivalent or they're cost effective, right? And I think that this speaks beyond just TB in that we need to have integrated testing, right? And so I think there's a lot more accessibility to testing for HIV and viral loads, hepatitis B and C, HPV, diabetes. And we need to, as a community, put more pressure to getting these tests out, not only for TB, but as TB as a component for integrated testing throughout and for vulnerable populations. And only then will you really see the cost effectiveness playing out huge dividends in preventing diseases and promoting good health far beyond the national TB program siloed approaches. Yeah. Dr. Celso, I don't know if you want to add anything towards that. On the cost
yes, I completely agree with you. This is a game of numbers, and the component of being able to have multi-disease testing is really important. When I look in our setting where we also have a high burden of HIV, so having a device where you can test for TB, but then have HIV viral, hepatitis B, and during COVID testing also was a big advantage. And I think that brings the costs really, really low having this type of instrument at the periphery of the health system.
Thank you. Adam and Celso, what does this study mean to accelerating TB response in the next 62 months? We have committed to, countries have committed to end TB by 2030.
Yes,
Yes.
if it sounded as easy as it was, we would be there, right? I think this is a demonstration that it is achievable if we have the political will and commitment, and I dare say unlimited funding to do this, right? I just came back from the UN General Assembly in New York, and while it's an important meeting to get everybody there and to be able to have messages heard, as a scientist, I feel frustrated that it just tends to be a lot of talking and people saying this is important, this is important. But where is the action? Where is the output? Where is the evidence that drives those policy shifts to save lives, right? And I think we've got to have a groundswell from people in demanding accountability from our politicians to move this forward. We demonstrate that with tools that we have in place now, we can do this, right? There is a very broad and rich pipeline of diagnostics that are coming through, and not to discount that and the impact that it has, but we absolutely have the tools in place now. And it's more about getting the commitment from the politicians and the governments and the people to save lives, and we need to demand that from a ground level. Celso, any comments on your side?
Yeah, it's a very difficult question, but I mean, with this publication, we are also trying to influence change and quick change. And I was discussing with Adam that we should have a policy brief, and the National TB program in Mozambique is requesting for this, because this will allow them to change their policy very quickly. So I think, I mean, we are doing our part. If everyone is doing their part, we can very quickly try to change things. But as Adam said, we need civil society, we need the politicians to do their part. And for us as health professionals, we are showing the evidence, but we need everyone to come together to make this change of paradigm in terms of access to care.
Mm-hmm. And I think also just to hit back again on the integrated testing, right? It's not only about TB, we need to address all healthcare needs. So I think the multiplexing component of this test and the large range of menu, the large menu of tests that can be performed is important, because it means that the investment that's made now will continue for years to come, instead of waiting for the technology to catch up on the next thing that we have to do.
Thank you, Adam. Thank you very much. We are fortunate to have with us Dr. K.S. Sachdeva today. He has played a great role in shaping India's TB response. Sir, would you like to say something?
Thank you, Shobha. Let me see. First of all, great congratulations to the researchers, Adam and Celso. You have generated a very important piece of evidence. What we always knew intuitively, that decentralized testing will be a game changer, but you always need an evidence to all these things. And here you provide a very good evidence to decentralized point of care testing and the outcomes it can bring in. This gives me back, I also read that Ugandan article on Uganda, where they have compared centralized versus decentralized gene expert testing, and they used a model. I actually written a commentary on it in Lancet at that point of time, where I argued on costs in centralized versus decentralized. And Adam, you pointed out, and I think in that study also they pointed out a certain number of tests where the costs break even between a centralized test and a decentralized test. And what you're currently arguing, also they were also doing HIV testing. So we had to combine HIV with, they combined HIV with TB, and they could see a cost breaking even in both the paradigms. And the outcomes, of course, are much better in the decentralized testing. Having said that, in the current context, when the definitions of presumptive TB are changing between what was the Ugandan study and now, it has more relevance because that time you were only looking at passive case findings. So you were only testing patients who were, or presumptive TB patients who were coming to your health center. Now you are looking at active case findings. So your definition of presumptive TB has changed. You now want to look for patients who are not symptomatic. It's a total change in definition. And symptomatic patients will never come to asymptomatic will never come to a health center. So that's where these findings are very useful. The more decentralized, the more easier it is to do a active case finding in the community. And people use various, again, definition who is eligible for an active case finding. I was just before the start of this session, I was talking to one of the district TB officer from India, and he said we use a definition of vulnerable population for active case finding. So this definition also varies from country to country, district to district. If you want to diagnose asymptomatic, then vulnerable, everybody is vulnerable. Then they using the definition that you are a smoker, you have diabetes, you are HIV positive, you are immunocompromised, then, or you stay in a highly congregate settings, as the definition of vulnerable, that doesn't hold ground. And in one of the study in India, in a state of Kerala, they used an index called a vulnerability index to screen patients and find TB. That study showed that if you use a vulnerability index, you can, with less resources, you can get more patients diagnosed very quickly. But at the same time, what was not shown there, or the study did not present, was that with vulnerability index, you are actually also missing about a third of the patients who are not classified as vulnerable, but they are still there out in the community. So, I mean, it's not captured in the study per se, but you get 2/3 of the patients very easily, and with less resources, you don't have to put in much efforts, and you get a majority of the patient. Good for programs which are in early stages of implementation. When you talk of elimination, then the concept of vulnerability, you have to do away with that concept of vulnerability and expand that definition slowly and progressively as you have more resources, both human and financial, from various sources, and then go out to the community, do an active case finding with a broader definition, and find all cases. And that is what actually will be the last nail in TB elimination. So the more we can asymptomatic we can get on board on treatment, the easier it will be to reach the 2030 goal of eliminating TB. So these are some of my thoughts. Happy to for any questions or comments.
Thank you very much, sir. Thank you. Very important points you have raised. We also have Dr. R.K. Sood, District TB Officer, in a very difficult mountainous terrain of India. Sir, would you like to make some comments? Because you have been following this, what the study has now actually confirmed scientifically. You have been doing it at your level. Would you like to say a few words, sir?
Thank you, Shobhaji. And I think this is a very, very relevant study right now. Because whenever we, am I audible?
Yes, very much.
So whenever we advocate for more NAT machines, the answer we get is that what is your utilization of the existing machines? Will you be able to utilize more ones? Like, this is a perfect argument that placing a NAT machine nearer to the peripheral level makes more sense. Like India shifted to upfront NAT in the 100 days campaign, which started from 7th December. So all our DMC HR is idle presently. So all lab technicians who were in the designated microscopy centers, they are without work because we are not doing microscopy. for diagnosis. So placing the NAT machines at these points makes more sense because we have the existing manpower, we just need to put the equipment. So I think this makes a perfect case for scaling up of the NAT to further lower levels. And I think this TrueNAT doesn't need a AC, it's a point of care test. So I think that, and we have solutions of 2 module also for low load facilities. So I think it makes perfect sense to have this decentralized NAT facilities. And at this point, when we are nearing the end TB milestone, I think we need to scale up this NAT facility. And I think people who are putting people earlier on treatment, putting people saving their lives, I think that makes perfect sense for NTB.
Okay, thank you, sir. Thank you very much. And with this, I think we have already overshot our time. So thank you to each one of you for being with us today. Special thanks to Celso, Adam, Arlena, Sriramji, Samantha, Lisbeth, and all the other participants, Dr. Sachdeva, Dr. Sood, and the others also. And when every spoke can be a hub, then it is high time to do away with hub and spoke model, I think so. If we are to end TB, we need to follow the science and take a person-centered and rights-based health and social support services closer to the people. This randomized control study provides path-breaking science to call for transforming every spoke into a hub by deploying point-of-care molecular tests like TrueNAT at the point of need, basically. More importantly, as has been said by Adam also, TrueNAT is a multi-disease molecular testing platform for over 40 diseases, such as TB, HIV, including viral load and testing, hepatitis B and C virus, HPV, the human papilloma virus, which causes a lot of cervical cancers, several sexually transmitted infections, vector-borne diseases like malaria, among others. So we need to make full use of this. And as we know, 10 days ago, while launching an important WHO report on antimicrobial resistance, the WHO Director General, Dr. Tedros, also had underpinned the importance of rapid and point-of-care molecular testing for preventing AMR, antimicrobial resistance, because correct and timely diagnosis for multiple diseases must be made accessible to all equitably, especially those who are underserved. So I think there are a lot of take-home lessons from today's session, and different countries would try to implement the science behind it. There was a lot of qualitative evidence, and now the quantitative evidence has also come there. So thank you very much. And once again, a very happy Diwali to all of you. We are still celebrating this festival of light in India. It's a long drawn out festivities for 5 or 6 days. So may the light of today's deliberations dispel the darkness of TB. That is what I hope. Thank you very much.
Thank you.
Thanks everyone. Yeah, thank you.